more than 20,000, but not more than 100. So several studies, like I said, are trying to find what is the lower limit. How low can we go for these drugs to be effective? And like I mentioned, there are already these trials that are looking into that, where clinical, and meaningful efficacy of the TDXD is observed, and that is also planned for future trials as well. So these are the examples of the HER2 low category. So you have the HER2 IHC score 1. And remember, for HER2, we only score membrane. And then on the right, we have a 40x micrograph of a IHC score 2+, which turned out to be ISH negative, and was negative. So these are what we would call a 1+ and a 2+ ISH, which was considered ISH negative. So this is a list of all the trials that have, been conducted to treat HER2 non-amplified cancers. All these trials, but they failed. All of these trials that are listed down here, all failed. And so in general, blocking or inhibiting the downstream pathway only works if HER2 is the driving alteration. So in HER2 low, the ADC, the reason the ADC works is because it only uses HER2 as a target. So then what is the difference between TDMI, because that was another ADC, and TDXD, which is the Enhertu that has been approved? So if you look at TDMI and TDXD, which is Enhertu, the payload or the chemotherapeutic drug for TDMI is anti-microtubule, whereas for TDXD is topoimerase 1 inhibitor. Then when you look at the drug to antibody ratio is way much higher, almost more than twice higher in Enhertu than it is in TDMI. And it has a linker that is cleavable. And the other advantage and the reason why TDX2 or TDXD or Enhertu has really worked or has shown efficacy is because it has evidence of bystander anti-tumor effect. And so this is the first time that we have the first antibody drug conjugate that has shown effect in tumors in HER2 low, so with much less HER2 molecules on the surface. And that's the reason why it's delivering therapy to HER2 low expressing metastatic breast cancer tumor cells. It has been quite effective. So we have mentioned that antibody drug conjugates are monoclonal antibodies. They're coupled to the payload, and the payload depends. It could be a cytotoxic drug, it could be a protease, it could be many things. And because it's targeted, it's bound to the HER2, the cytotoxic compound reaches those targeted cells much more directly, and also therefore reducing potentially toxic side effects. And it relies on the expression of the protein target, so it doesn't inhibit the protein target, so it doesn't inhibit HER2 itself, but what it does, it uses it to deliver, like a drug delivery system. And then what happens, you then internalize the Enhertu, and that leads to the release of the payload, which is the topoimerase, and therefore you have subsequent death in the target tumor cells. And so the highly potent payload, remember we said it's an 8-to-1 drug to the antibody in terms of the concentration, and it also therefore also has a bystander anti-tumor effect, and that's the reason why it works, and it has shown to work. So a bit more on the trials. So Destiny Breast 04, what was this trial about? It was a phase 3 trial of ENHER2, compared it to second line and third line HER2 negative monotherapies for HER2 low breast cancer. So these were the eligibility criteria. The patients had to have been diagnosed with HER2 low. Like we have mentioned, it's HER2 1 plus or HER2 2 plus, which is non-amplified, unresectable, locally advanced or metastatic in the MET setting. They have already previously been treated with 1 or 2 lines of chemo in the MET setting. If they were hormone receptor positive, they must have been refractory to endocrine therapy. No restriction of prior, so there was no restriction if they'd received prior targeted therapy. And then they were randomized 2-to-1 on the ENHER2 arm. So those were about 360 patients. And then on the other arm, which is the 180, the investigator's choice. So capecitabine or nab-paclitaxel, so those were the paclitaxel, so those were the drugs, physician choice drugs. And so the primary endpoints in the hormone receptor positive was the progression-free survival, and then they had progression and secondary endpoints in overall survival in the hormone receptor positive, in the hormone receptor positive and hormone receptor negative, as well as progression-free survival in both, right? And then the secondary and key secondary, and then the key other endpoints were the overall survival as well. So let's go to the results. And so what did they use? They used the Roche HER2 4B5 assay system. And this was done at a central laboratory, and it followed the 2018 ASCO-CAP guidelines. So the following criteria were also considered for patients' eligibility, like time and type of fixation, because of course we know that can affect how you interpret and score your HER2. Then specimens were fixed, and 4-micron sections. So you can see how the usual way that we are used to. However, decalcified bone metastases were excluded. FNAs, if they didn't have at least 50 viable cells associated with the stroma, were excluded then. So then, like I said, this is exactly what's indicated here. And so what did they find? And you can see that if you look at the blue line here, the number of patients, 331 in the ENHER2 arm, 163 in the other arm, and you can see really there is almost a 6-month median overall survival in those in the hormone receptor positive cohort that were HER2 low, and much better survival than overall survival than in terms of months. And then when you look at among all the patients, whether they were hormone receptor positive or hormone receptor negative, again, the ENHER2 offered a distinct survival benefit that was clinically and statistically significant at 23 months. And so, let me just go back. So we know that the benefit of the progression-free survival benefit of ENHER2 was consistently observed in patients with IHC 1 plus, so 10.3 months, and IHC 2 plus, 10.1. So there was not much difference whether they were IHC 1 or IHC 2 that were not amplified. So then this really indicates to us that the number of HER2 receptor molecules, that is about 100,000 molecules, reached the threshold for the unique bystander killing effect of ENHER2 in HER2 low expressing tumors. So there was not much difference. So you can see it doesn't matter whether you had 100,000 molecules on the surface or more than 100,000, like as in HER2 2 plus, So if you look at HER2 2+, it's about more than 500,000. So it doesn't matter. So that threshold of 100,000 is good enough to be able for the drug to be effective. Let me just go. And then in terms of the tumor sizes, they also found, first of all, an additional secondary endpoint they wanted to look at is to see the best change in the size of the target lesions for patients who are hormone receptor positive, low HER2. And they found that in the NHER2 arm, the majority of the patients experience consistent reduction in tumor lesion regardless of their IHC score. So if you look at the graphs here, the dashed upper lines, you can see the dashed upper lines in the plots, they indicate a 20% increase in tumor size in patients with progressive disease, and the dashed lower lines indicate partial response and a 30% reduction in tumor size. So we can see that this is like more like a waterfall plot for these patients who received NHER2. And patients treated with NHER2 were shown to have a significant reduction in measurable tumors compared to standard of care chemotherapy. And those who are HER2 IHC 1+ are shown in the dark blue here, and the lighter blue are those who are HER2 IHC 2+ and non-amplified. So you can see that there was quite a bit of a difference in the tumor size, as we can see there in the graphs. So how low can we go? How low? There's the DAISY trial. It investigated at different levels of HER2 expression. It's an open-label, multi-center, phase 2 study. And the question is, 3 cohorts of patients with either HER2 positive, HER2 low, or HER2 less than 1+ were included in this one. And we can see that the best objective response is like you see a decrease from 71% in those who are HER2 positive to only 30% in patients with HER2 IHC zeros. So we need to now see what future studies will show where can we cross that line, and what are the treatment risks, and what are the cost versus clinical benefit. So currently, as we stand today, NHER2 is not approved for patients who are less than IHC 1+. So it's only for those who are IHC 1+, IHC 2+, non-amplified, hormone receptor positive, or hormone receptor negative, as currently. So the Destiny Breast 06 trial, we know that the Destiny Breast 04 showed the efficacy of NHER2 in HER2 low metastatic breast cancers. However, there are lots of studies going, looking into, can we find a lower limit still? And that's again going to be in the Destiny Breast 15. So there's still ongoing trials. So we can recapitulate that perhaps, and it's likely that the treatment landscape and the future testing will definitely evolve over time as more and more therapeutic targets are found and discovered and found to be effective in the HER2 low and perhaps even the HER2 ultra low. So one thing we need to remember is that much as we want to give this antibody the new targets therapies, we do not want to give them drugs without testing and without the clone and testing with the clone that has been found to really be the companion diagnostic for Enher2, which is the 4B5. Because you can have unnecessary safety profile and unnecessary side effects. And so that's a really important consideration when you're looking at the benefit risk profile of Enher2. And you can see that this slide actually, summarizes all the adverse reactions that occurred in more than or equal to 10% of the patients for all grades. And then for up to 2% of the patients for grade 3 and 4 in the Destiny 4 trial. So nausea, vomiting, constipation were grade 1 and 2. And these patients had received 8 months and 4 months of chemotherapy for those who received chemotherapy. So those are the major side effects that have been found through in this specific trial. And the major one that is for Enher2 was really the interstitial lung disease and pneumonitis. And so there's actually a warning label on the drug that you need to be aware of this, and you need to be monitoring these patients who are on Enher2 for this interstitial lung disease and pneumonitis. So these are the, and this is the actual label, and patients should be investigated if they are found to have. So what are the key points of the Destiny Breast 04 clinical trial? That Enher2 or trastuzumab deruxtecan is the first ADC, or the antibody drug conjugate, which has been shown to show clear benefit in HER2 low metastatic breast. And this is because of the trial, the randomized controlled trial, the Destiny Breast 04, that led to its approval in 2022. That it is the 4B5, clone of HER2 that was used in this specific trial, and the ASCO CAP 2018 guidelines that were used for scoring and to determine whether these patients fall into HER2 low. And those who are eligible for the trial. And so the results have the potential to improve the treatment outcome for more than half of the patients historically categorized with HER2 negative breast cancer and therefore not previously eligible. Of course, we are aware that we need to be aware of the side effects. So testing is of key importance, and as pathologists, we play a key role. So if you call somebody 1+ and it's actually a 0, then one needs to be very cognizant of the fact that that could pose more harm than good for the patient. Also recall that in the Destiny Breast 04, those who are IHC less than 1 were not included and therefore are not eligible for treatment. And so, however, the Destiny Breast 06 trial, they were investigated patients with those who are between a 0 and a 1, and so this in future may expand. So we need to keep abreast of what's going on in this space. So I think, so I think I'll stop here because Priscilla will take you through the scoring of the HER2 and so that's, and I will allow Anne to go first, and then Priscilla can come back in the after tea break. Thank you very much. Then perhaps we can take questions at the end of this session before tea break. So we'll allow Anne to go. Is she online? Do we know? Anne, are you online?
Yes, I'm online. Okay. I cannot turn on. Can you hear me?
Yes. Yes.
Okay, yes. Great. Okay, great. Okay, great. So I share my screen, correct?
Yes, I think so.
So let me just find where it is. Screen 1, yes, I think it's this one. do you see, oh, what's that? Do you see one slide or two slides? Hello?
One slide.
Okay, thank you. Because let me just, okay. And can you hear me in the room?
Yes, we can hear you. We can't see your slides.
Okay. So, hello everybody. Nice to be with you today. Thank you to
Hello,
Shine for
hello, Anne.
inviting. Yes?
Please hold on as we sort of issues inside.
Okay.
Yeah. It's okay. It's okay. Peter? It's okay. It's okay. Yeah. So, Anne, you can carry on, please. Thanks.
There is a big echo. Can you hear me well?
Yes.
Okay. So, thank you all for being present this morning and this afternoon and tomorrow. Thank you, Dr. Shahin, for inviting us as a speaker. So my name is Anne Weidelich. I'm French. I'm based in France. I work in the pathology area since more than 20 years. And also I'm involved in AQA and education, internal education, and education for pathologists. Today, I'm going to speak about quality and best practices in breast cancer. So the agenda will be looking into the pre-analytics, the assay, and some other topic around quality. So when we think about the stain slides, there is a different things that needs to happen before to get a proper stain slide that can be interpreted and scored. The first thing is the time to stabilization. That is very important, and it has to be below 1 hour, because otherwise, as you know, the tissue and the enzyme will start to degrade the protein, and at the end, the tissue will not be, the analysis that will be performed will be bad. The second very important factor is the method of stabilization. And this is the recommendation from the international group is 10% neutral buffered formalin at pH 7 and more than 6 hours and less than 36 hours. Then the method of processing, it's very important to slice the sample, the breast at 4 to 5 millimeter section, and to have a volume of fixative versus the volume of the sample from 10 to 1 or more, but we try to limit space, and that the tissue processor is using a low melt paraffin, and also that the fluid are changed regularly and that the processor is maintained regularly. Finally, it's very important to have a storage condition, dry, pest-free, and room temperature. And the last point that is very important is to document all of this or any deviation of this for each sample. Because when the result will be bad, if you have documented everything that is written of the pre-analytic with the sample, you can look afterward what went wrong. So this is not coming from my brain. it's ASCOCAP that decided to task a group, and they say to this group, you have to tell what are the most important parameters. And the paper, the reference is below. It's Dr. Caroline Compton, and she was in charge. And the way they work is they say there is so many parameters in pre-analytics that if you want to have all of them right, it's a bit discouraging because every step can go wrong. So really, they look at all the scientific articles that were published, and they really concentrated on the most, the 20% of the factor that was making 80% of the problem. And that's how they come with this very short list. For sure, there is other analytic steps that are important, but if you get these short lists of pre-analytics right, you will solve 80% of the pre-analytics problem. So it's already huge. And now, just to illustrate, if you are not convinced, these cases were shared by Dr. David Hicks from USA. And so he looked at the tumor, and I'm not a pathologist, so I will not go into the detail, but he looked at tumor, and he decided to run ER, and ER was negative. He was really surprised. He looked at the internal tissue control, the on-site control. So the cell line batch control was good. The on-site tissue control that was endometrium was good, but the internal tissue control that are the normal glands were negative. So he knew that something was going wrong, not with the test on the instrument, but with the sample itself. He went into the report. He went into the report, and he saw that the collection time of the sample was at 5 p.m. on October 8th, but that the sample was put into fixative only the morning after at 8 a.m. the 9th of October. And then it was fixated 18 hours. So the time to fixation was overnight, and that's why the sample was negative. So they required that a new specimen was taken from the patient, because retesting this sample would have been useless. And when they retested the patient, the new sample, this time ER was positive. So this is to illustrate the cold ischemia time that has to be below 1 hour. As short as possible. In fact, it's described in the document, but to be realistic, it's below 1 hour. This is another illustration of delay of formalin fixation on ER expression in breast cancer. And you can see that there is 3 different clones that were used. So it's not specific to one antibody clone. There is SP1, 6F11, and 1D5 clones that were used. And you can see the delay to formalin fixation. Either the sample has been put, and it's the same sample, directly in fixative, so 0 minutes, 4 hours, 8 hours, and overnight delay fixation. And the more the delay to fixation is big, you can go from a highly positive ER sample to a fully negative. So this parameter is really important. And there is also this study that illustrates the difference between in lab between regular handling, that is the light blue bar, and the prolonged handling during the weekend. And you can see that strangely, the ER case that are negative, which is the bars, is increased when there is prolonged handling of the sample. So that's the proof that it has a big impact on staining. Then there is also the time of fixation. And if you remember in the first slide, I said it has to be more than 6 hours and below 36 hours. People tend to think that if I have a tiny sample, so a biopsy, fixation can be short. And this is not true because fixation is happening in 2 steps. First, the fixative enter into the tissue, and then the formaldehyde makes cross links with protein. And these steps take some time. And that's why even a tiny biopsy should be at minimum 6 hours in fixative. And here you can see the beautiful illustration that even 6 hours is on the edge because the morphology is not that nice. At 3 hours, it's almost a negative case. And when it's 8 hour fixation, you can see the beautiful morphology of the nuclei. This slide is just to illustrate on the top, this is the ASCO-CAP guideline recommendation for HER2, ER, and PR testing. And below, it's the paper I refer, which is a great paper for Caroline Compton and all. So time to fixation, they all agree it's 1 hour of cold ischemia time maximum. So as short as possible. Fixative type, the same, 10% neutral buffered formalin pH 7. In the ASCO-CAP guideline, they don't speak about decalcification. In Compton article, they really point that you must not have acidic decalcification because they really want that molecular analyses are good and acid decalcification will destroy the nucleic acid. Fixation time, ASCO-CAP, it's from minimum 6 hours, optimal 24 to 48 hours, and they allow a maximum of 72 hours. And in the paper of Compton, they really say that it's maximum 36 hours and up to 48 hours for fatty tissue. And they don't want you to fix 72 hours. The 72 hours was not in the previous version of the ASCO-CAP guideline. They added this information to match the weekend the weekend time. So I think it's better to try to go below. And the volume, ASCO-CAP guideline recommend 15-20 volume of fixative for 1 volume of specimen. And they explain that large specimens have to be sliced. And it's the same for Compton. They reduce the volume because they also try to be realistic with the cost and also with the space in the lab. And a volume of 10 volume of fixative for 1 volume of sample is enough to do a great job. Finally, to conclude this part on pre-analytics, this is, and you will get the material, this is a list of all paper reference and also some Bright Talk webinar that you can look on pre-analytics. And now, just shortly about the assay. There is always a big debate about which assay to run for HER2 for ISH, and ASCO-CAP had recommended that any FDA-approved IHC, bright field ISH or FISH assay, it's difficult to say, FISH assay can be used to determine the status of HER2 breast cancer. The last part of quality, once we have done a right pre-analytic, is to have careful in mind 3 pillars, which are the on-site controls, monitor the rates, and the external quality assessment. So on-site control for HER2, what is recommended is to have a range of expression of HER2. So 0, 1 plus, 2 plus, 3 plus. Some people use cell lines. which is absolutely okay. But otherwise, you have to do some work in your lab and use former block to make those control blocks. For ER, you can use uterine cervix as positive control, as well as tonsil, which have some compartments that are negative. And for PR, it's uterine cervix, and tonsil should be negative. And for K67, it's also tonsil that can be a good control, positive and negative. And you can also use liver and pancreas that are source of negative control. And here it's the illustration with a picture taken from Nordic QC website of the kind of control you should get for the 4 markers. The other things that is good to do in your lab is to monitor the positivity or negativity rate, because it will indicate if suddenly you are out of range, then you know that maybe there is something happening in the lab. So the numbers there are a range, because in the literature it varied, but triple negative breast cancer should be around 15 to 20%. The HER2 positivity rate, so means the HER2 IHC3+, and the HER2 that are IHC2+ and amplified by I stage, it should be around 15 to 20%. The ER-PR positive should be 70 to 84%, and the HER2 low should be around 50%. These are, we wrote to be followed up, because this was the number from the clinical trials, and the more they are testing, the more we get number from everybody. So the way positivity rate have to be followed is you do this, you monitor this, and if suddenly you are off, you can, let's say, start to think what's going on. It can be that suddenly you get sample from another lab that change your percentage of HER2 positive, because maybe you get from a lab all their 2 pluses to run ISH, so for sure then your HER2 positivity rate will change, but at least you are in control of what's going on in your lab. The third pillar of quality is the participation to external quality assessment schemes, and I'm gonna try to convince you, if you are not convinced, about why is it important. You can see that there is 2 labs, A and B, that are using a positive control tissue for keratin. So they are happy. On each slide, they put an on-slide control piece of block and the patient sample. The problem is, like, when they test the same patient sample, and all these pictures are coming from our DQC website, the laboratory A is saying that the patient is negative, and the laboratory B is saying that the exactly same patient sample, the test is positive. So who is right? Is it laboratory A or laboratory B? It turns out that the laboratory A was not using the right control tissue to set up his protocol. So he established the protocol with a tumor that is a high expressor, and when he's running this protocol on a low expressor patient tissue, the patient is negative. The second laboratory B, is using liver as a control tissue, and he has set up the protocol. He has a totally other protocol, because in liver, not only the biliary duct should be positive, strongly stained, but also the hepatocytes. And to get the hepatocytes positive, you have to push the protocol. And so laboratory B is using the right positive control tissue. Therefore, he has set up the right protocol, and he is aware about slide interpretation, that hepatocytes should be positive, and that's why in this lab the patient sample is positive. And this, if you do it alone, you cannot detect, because laboratory A, they think my positive control is positive, that's okay. By participating to external quality assessments, they got the feedback that their positive control was, their protocol was not good, and they could change it. There is a lot of external quality assessment program around the world, and in Europe there is the famous Nordic QC. I say famous Nordic QC because their website is accessible and is very good. And I see that I forgot to put it on the slide because I always speak about them. That's why. So it is recommended to participate to external quality assessment as per ISO 15189. Also in the ASCO-CAP HER2 guidelines for breast cancer, it's written that the lab should participate to external quality assessment. If your lab, if you're based in US and you have a clear certification, it is recommended and also as best practice. And now I just want to illustrate data from Nordic QC, where they compare HER2 clones over the years. And you can see that the orange line is the pathway 4B5 that had constantly performed good during since 2012, since it's on market. And also another paper from Nordic QC, where they looked at the performance of companion diagnostics versus lab developed test, and this is for HER2 and PD-L1, and they seen that, and they look at every supplier, not only Roche, and they show that there is a constant overperformance of companion diagnostics versus laboratory developed test. And there is another paper on the same topic that is a bit less recent, but showing the same thing. The top greenish blue curve is the FDA CDX assay, and the bright blue curve is the lab developed assay. And they show that over the years, the result improved, because you see that the lab developed assay curve is going up because people master better IHC, they participate to AQA. So overall, everybody improved, but still the ready to use FDA assay are more stable and perform better compared to LDT. And finally, the last slide is to speak about the 3D approach to purpose in companion diagnostic testing. So it's the fit for purpose. There is a drug, a disease, and a diagnostic tech for a purpose, and that's why it's very important that during the clinical trial, the efficacy of the drug was established in participants with a specific disease, and where the biomarker testing result with a specific diagnostic assay on the biospecimen to make the trial of the patient that could successfully distinguish which participant will show clinical response to the drug. So everything is linked together, and if you take another assay that was developed for another drug, the results are different because everything is linked to the clinical trial. I hope it was clear, and happy to get questions together with Dr. Shine. I don't know how to escape my presentation. Here I am.
None, I hope the presentations were clear. Are we having a tea break now? So there's a tea break. Where is it again? Ground floor. So there's a tea break for those who are here. We reconvene 15 minutes. Okay, hopefully in 15 minutes. And then photo session now. Okay. All right, for those who are here. All right. Thank you very much.